Ladies and gentlemen, it's an honor for us to introduce Dr. Ben Zendejas-Mummert. He's the Surgical Director of the Esophageal and Airway Treatment Center at Boston Children's Hospital. Dr. Zendejas-Mummert is a renowned expert in the field specializing in the treatment of esophageal atresia and other complex airway conditions. And with his expertise and dedication, he was able to improve the surgical outcomes of a lot of children and is a leading authority in the field. He has innovative approaches, especially to the topic he will talk about today, which is tracheomalacia and vocal cord dysfunction, ways to how avoid complication and when to wait and see. Ben, please, the stage is yours. It's a great honor for us, and thank you for your time. And yeah, it's yours.
Thanks, Martin. It's been great to see you in the last few talks. I love to see the progress and how far we've come in the field. I still think we have a long way to go, and this is sort of the focus of this talk, trying to reframe the way we see this disease, as was already said earlier today, as more than just the esophagus. I'm going to use two examples of how the way we treat and address the airway can impact significantly the respiratory morbidity that children can have. So this is a fairly common scenario in most places where there's a specific or mostly pediatric surgeon-centered approach. And I get this story all the time, not just from patients and parents, but also from some providers where there's a newborn with an esophageal atresia, esophageal fistula, and the mentality is I must fix the esophagus. And this is, we're all guilty of that as pediatric surgeons. We may focus just on that. And we've gotten pretty good at fixing the esophagus. So we say, okay, well, the esophagus looks great, but why is this child not doing well? He's having infections, he's having difficulty feeding, he's aspirating. Well, when you get a little bit more into it and you evaluate things, which is already one big step, a lot of these kids get misdiagnosed as asthmatic, croup, and other things that have nothing to do with what they truly have. This child, for example, has tracheomalacia and vocal fold movement impairment from a recurrent laryngeal nerve injury at the time of his first operation. This is actually a fairly common scenario. And the pediatric surgeon says, well, you know what, the esophagus looks great. I don't know what to do. It's not my area expertise. Let me refer you to pulmonary, ENT, ORL, GI, who in turn sees them. But since they don't often see kids with esophageal atresia, they just sort of in general see kids who have respiratory infections and aspiration. They say, well, you know what, there's not much to do. We'll give you some antibiotics. We'll give you some inhalers, and we'll wait and see. We'll wait for you to grow out of it. Don't worry, they all grow out of it. This is a very common thing parents, patients, kids get told. Unfortunately, this sort of haphazard approach is bad because the child struggles with respiratory issues most of their life and gets lost to follow-up because they don't necessarily get the care they need. Now, let's contrast that with what I would propose should be the way to do it. And I'm glad to see that many of the centers that have already been presented their experience and data is already, on board this wagon, if you will. This really has to be a patient-centered and not a pediatric surgeon-centered approach. It needs to be a multidisciplinary care team from the very beginning, not after the fact. And it needs to be a treatment that goes beyond just the esophagus. What do I mean with all of this? So you get a child with an esophageal atresia, esophageal fistula. You must say to yourself, let's fix the esophagus, the airway, and prevent morbidity. And what do I mean with that? There really has to be a proactive, preemptive management of tracheomalacia. All these kids have malacia. It's just the spectrum, but we have to treat it. And the way we treat that nowadays is every kid gets a primary posterior tracheopexy to prevent respiratory issues down the road. Now, you do that also by preventing injury to recurrent laryngeal nerve, which actually happens fairly frequently. We just never measure it. We don't look, as Martin was saying, if you don't look, you don't know. I'll show you some data as to why that's the case. But if you prevent recurrent laryngeal nerve injury, that's a huge advantage for these kids. You have early involvement of this multidisciplinary care, more frequent surveillance and follow-up, and something that's going to Michaela talk about in a little bit, which is very important, is you measure their patient-reported outcomes. Let's get beyond mortality, leaks, and strictures, which is our own surgeon outcomes, and get more to what matters to the patients and the parents as to how is their daily life, how are they living, what can we do better? And then another big thing that's already been said today is we really need to empower and prepare these patients and parents for this adult transition. We're going to get more and more adults as the disease evolves, and we're not prepared for it. We need to be prepared for that. With all this approach, I do think that the child and the adult thrives, and also the surgeon and the care team. So how do we get there? really thinking that esophageal atresia and tracheal fistula is a field defect. It's not just an isolated condition. The malformation is of the esophagus and the airway and things beyond there. Because the esophagus doesn't live in isolation in the mediastinum. It lives around nerves, blood vessels, bony structures, the lung, etc. So everything needs to be taken into account. So in the repair, you need to address not just the esophagus. We'll get into that. So I could show you all sorts of graphs and data as to what the burden of respiratory disease in esophageal atresia is. You know that. But I'm going to show you one video that's very powerful, and it's actually hard to watch. But this is a child having a blue spell. And it really showcases the magnitude of what happens to these kids. So that's hypoxia to the brain. That's not good. And these kids have blue spells all the time. Not all kids, I agree, but some do. And there's a very easy way to prevent them. We'll talk about that. So what is this child having? Why is he passing out? Why is he having a blue spell? He has tracheomalacia, plain and simple. This is not something weird. This is malacia, okay? It's just an abnormal structure of the airway where a normal airway should have normal C-shaped cartilages, narrow membrane, and respond to cough or dynamic effort as not complete collapse. 40, 50% is normal. Now, contrast that with an airway of a child with esophageal atresia. Broad bow-shaped cartilages, significantly more posterior membrane, a lot more collapse with just very little respiratory effort. That's why that child was passing out with a blue spell. Now, the reason why it happens in esophageal atresia is that structurally they were born in order to accommodate the fistula, particularly all the kids that have a fistula to the airway. In order to accommodate the fistula, their airway is wider, they have more membrane. And we know that the wider the membrane, the more risk of intrusion. And what's intruding is the esophagus, because we're fixing the esophagus from the right side. We're pulling the esophagus a little more right, where the esophagus ends up being behind the airway. And if you have a little bit of esophageal stricture, dysmotility, you call it, and you leave a diverticulum, which is another big component of things, then you're going to have malacia issues, right? So let's get to the symptoms, right? Not all kids have blue spells. Yes, some have blue spells or fail to extubate. Fail to wean respiratory support. Others have prolonged respiratory infection, pneumonia, bronchiectasis, trips to the hospital, you name it. Or it can just be like totally fine. But they cough like that, and everybody looks at them at the supermarket and says, your child's sick. And you're like, no, he's not. And so they have impact on their daily quality of life. Or some actually are asymptomatic, but I would say that they're the rare few. Now, why intervene? Don't they all get better with time? Everybody tells us. Like, where is this data? I'm still looking, and I will keep looking, and there's absolutely no data that esophageal atresia kids with malacia grow out of it. They may adapt. They may be different presentations, different symptoms, but not all get better, right? And particularly, we don't know who will and who won't, and how long does it take? And while you wait, what's the cost? What's the burden? Right? How many pneumonias, hospital admissions is one too many? And the truth of the matter is malacia is present in all age groups, including adults. So they don't grow out of it. You just stop seeing them. They go to see somebody else. So who needs treatment, right? Not everybody needs a surgical procedure after the fact. So if you have severe malacia, severe symptoms, and severe endoscopic imaging, then yes, we are strong believers in addressing it with a tracheopexy. Multiple versions of it, multiple ways to get to it, but there's something to be done about it. That's I think a key message, not just waiting and watching it. Now, there are some kids who have bad-looking airways when we look with the endoscopy, but they have no symptoms, or at least very minimal symptoms. I mean, they're not getting sick, they're not going to the ICU. Then we do treat those medically, right? Inhalers, pulmonary clearance regimen, etc. But they're not asthmatic. They rarely are asthmatic. So it's a different treatment than the asthma treatment. Now, what is this posterior tracheopexy? Essentially, it's surgically stabilizing that posterior membrane, moving the esophagus out of the way, and stabilizing the membrane with some pleated sutures that are with autologous tissue. And we place a series of sutures on the back membrane and bring it back to the spine, and that stabilizes the membrane, prevents it from collapsing, right? That's in basic terms, that's what that is. And it increases the lumen of the airway and significantly makes the airway look better and function better. The origin of the posterior tracheopexy began with treating patients with recurrent tracheoesophageal fistulas. We were trying to come up with a way that prevented fistula recurrence by separating the suture lines. And we saw that in addition to preventing recurrence, because you were effectively separating the suture lines, the airway of these children got significantly better. And they have less respiratory symptoms, and we saw significantly less malacia. So we started to apply this strategy of the posterior tracheopexy, not just to treatment of recurrent tracheoesophageal fistula, but just children who had respiratory infections. And this is not something new. We started doing this in the early 2010s. And sort of this series of first 100 patients, if you will, showed significant improvements across the board in respiratory infections. You name it, everything from blue spells to barky cough, noisy breathing, significant improvements. Now, I like this paper that came out of Toronto not that long ago that shows the frequency of blue spells. Because when I've spoken to some surgeons, they're like, I don't know what you're talking about. None of my kids ever have blue spells. I'm like, that's not true. They're just not telling you, or they're going somewhere else. Like, we've seen some contemporary data that show that 1 in 4 or 1 in 5 children can have some form of blue spell or ALTI or BRUI, however you want to name it, in their first year of life. And for example, this series out of Toronto showed that they get all sorts of interventions, fundoplications, which is totally the wrong thing to do because it's not reflux what's creating this, it's malacia, or they get aortopexies, which is like a flip of a coin. They don't always work, particularly if you don't do it well. So recurrence after those interventions is high because it's not addressing the underlying problem, right? The underlying problem is the posterior intrusion or the malacia. And this is where this comes into play. And this data is under review. It's going to come out soon. And it shows that for this select cohort of patients, these were 80 children who all had severe symptoms, failure to extubate, blue spells. They essentially were told, you need a tracheostomy. So these were patients who sent to us because they either couldn't extubate, couldn't stop having blue spells, needed a tracheostomy. And we said, no, this is not a case where a tracheostomy is needed. They need a tracheopexy. And we had 100% effectiveness on recurrence of blue spells. And most kids were able to avoid a tracheostomy. The few that did not were because of issues with vocal fold movement impairment, already had cords injured before they came to us, or we had an injury, or subglottic stenosis issues, injury to the larynx or other issues, right? So very few truly needed a tracheostomy. Now, we went a step further and said, well, geez, if they all have, if the burden of malacia is so prevalent in all these kids, and they all have a structural problem of the airway, why not just fix the airway, but also fix not just fix the esophagus, but also fix the airway? And this is where this concept of the primary or prophylactic, if you will, posterior tracheopexy comes into play, right? We started doing this in all kids in our newborn cohort. So this was 63 newborns. Some got it, some didn't, and mostly was like earlier in the years and with other surgeons that aren't part of our specialty group who said, well, we're not going to do it. But if you look at the kids who did get the tracheopexy, which is this group 1, their first year of life is significantly better. No admissions to the hospital for respiratory infections, essentially no blue spells, and length of stay was even shorter. And even their nutritional status was better. It wasn't something I was expecting to find because they're less sick, right? They're eating better. If you can breathe better, you can eat better, and you're not getting constantly sick, and you're not having malnutrition issues. So this was a game changer, right? So in summary, I'm going to go into the vocal fold movement impairment, but in summary, malacia is a big problem. It's often misdiagnosed and underappreciated. They don't grow out of it. You need to treat it, right? And the best way to treat it is to treat it at the same time you're fixing the esophagus. But if that wasn't the case, then you also need to treat it after the fact, and that's where secondary treatment of malacia comes into play. Now, the other big culprit, and I think the other thing that can be preventable, is this. Vocal fold movement impairment from recurrent laryngeal nerve injury is also underrecognized. The left nerve is more commonly injured from the right chest because of its greater course into the right chest. These kids often have aberrant right vessels anomalies, aberrant right subclavians, and other things, and so their location can be abnormal. You need to know how to anticipate that. Now, historically, recurrent laryngeal nerve monitoring has been controversial because there's no quote-unquote devices available for children, but that's not true. We have a way to do it now, and I do think it's preventable. We need to shift our mentality away from it's not my fault, or it will get better. It doesn't always get better, so it's preventable. Now, we do all these great operations. We show these great pictures of like getting the esophagus together when it was a mile apart. We do all these traction systems and get the esophagus together, but then what's the point in having a great looking esophagus if the child aspirates everything they drink? They can't use the esophagus that you just created and spent all this, time and effort to do. This video isn't playing nicely, guys, but essentially showing that this child aspirates everything, right? So that's heartbreaking, right? So I really do think that the goal is no nerve injuries. That should be the goal. And we need to measure them, because if we're not measuring them, then we won't know. And why do we need to measure every kid? Because there is a big proportion of kids that are asymptomatic that have an injury. Now, we did the study to understand that. The study looked at all children that came to us for an evaluation in this 5-year period. And we wanted to see if we scope everybody, if we do an assessment of vocal fold function for everybody, how common is it going to be? Just the prevalence of this problem, right? We had 300 patients come to us for evaluation on this 5-year period. Most of them had a prior surgery at risk, prior EA repair of some sort. And 24% had a pre-existing injury. So 1 out of 4 had it, okay? Most of them had unilateral, some had bilateral, right? Most of their symptoms were related to dysphonia, but not all of them. Half of them did not have classic symptoms. So they were quote unquote asymptomatic because they weren't stridorous and they weren't having the classic dyspnea. So obviously the bilateral injury was more likely to be symptomatic. So what does this tell us? That this is common, it's underdiagnosed. Every child needs a screening before and after the operation, because actually there's a few proportion of kids that have congenital vocal fold movement impairment. You need to know that before you operate on a child. And symptoms are not reliable for screening. So how do we protect these nerves? We've published on this before. We can modify existing technology for adults to fit on a pediatric endotracheal tube and have sensors on the breathing tube and a circuit that allows us to monitor the function while we're operating close to the nerves for every patient, every time we do this, and it's great. It really makes a difference. So the data that shows that this is also going to come out soon, it's under review, shows that we did this study that looked at patients who had monitoring, compared it with those who didn't. Single center, 5-year period, and we looked at all of these patients had screening before and after, or at least we tried. About 660 patients initially were evaluated. Ultimately, 426 were part of this study. Most of them were small kids. Some of them were reoperative, the vast majority, 35%, not all of them, but 35%. They're young kids, right? Anything from a few days old to like teenagers, but mostly young kids. Airway esophageal cases, just only the majority. Now, significant reduction in nerve injury rate with nerve monitoring, significant, half, particularly with bilateral injuries. Almost we didn't have any bilateral injuries when we were using nerve monitoring, very few. Particularly, it helps the most when you know and you have a pre-existing injury and not hurt the other one. Look at this number needed to treat, just 3. So this is a graph of how things evolved over time, where we were doing 2018, we were not doing that great with screening. We were about 50%. Gradually, we've increased and we're about 85%, 90% screening. Every now and then one of those kids gets out of our screening pathway. We're trying to screen everybody. And now, as you can see, we use nerve monitoring in almost every case, 90%, close to that. And our injury rate initially maybe went up a little bit because we were screening more and we found more, or also part of the learning curve of using nerve monitoring. But each year, gradually, significantly less. And this is down to less than 10%. And this is measuring everybody. So it really is the true nature of it and not just the tip of the iceberg. So now we know that this is challenging, but it's very feasible in all age groups, including neonates. It's really effective at decreasing injury rate and vocal fold movement impairment. And consequently, the respiratory burden is significantly less. Now, I do think this should be part of the standard repair of EAT for kids. And so to summarize, these were just 2 examples. There's many more that we could talk about. They're just 2 examples as to how you can tackle or address 2 entities that affect the long-term outcome of these kids from the very beginning, just at the time of the repair when they're newborns, right? Let's get beyond just fixing the esophagus. Let's fix their airway and prevent respiratory morbidity by addressing these 2 things. And really monitor their outcomes. And this is sort of what Michaela is going to get into in her next talk, and I look forward to talking about that. But I go back to this slide that we started off at the beginning. Let's move from this specific pediatric surgeon-centered approach only that is focused only on the esophagus to really this patient-centered multidisciplinary team fixing the airway and everything else that goes in with that, because it matters. Thank you very much, and I look forward to the rest of the talks today.